Bismillahirrahmanirrahim. I'm Dr. Amira Sharqawi, lecturer of rheumatology and physical medicine. We will discuss juvenile idiopathic arthritis. Juvenile idiopathic arthritis is an umbrella term used to describe arthritis in children. The diagnosis is considered if there is arthritis of one or more joints persisting for more than 6 weeks with an onset before the age of 16 years, after exclusion of other causes of joint swelling such as infection, oncology, trauma, or other rheumatic disease. You should know the difference between arthritis and arthralgia. Arthritis means inflammation of the joint. There is usually visible evidence of inflammation as joint pain, stiffness, tenderness, redness, hotness, swelling, and limited movement, while arthralgia means only pain, subjective joint pain without signs of inflammation. These two diagrams show the difference between the normal joint and joint with arthritis. In the latter, there is inflamed synovial membrane, excessive synovial fluid, bony overgrowth, and thinning of the cartilage. Juvenile idiopathic arthritis is classified according to International League Against Rheumatism into 7 categories: oligoarthritis, polyarthritis with rheumatoid factor positive, polyarthritis with negative rheumatoid factor, systemic JIA, psoriatic arthritis, enthesitis-related arthritis, and undifferentiated arthritis. Oligoarticular JIA is often considered the most common form of juvenile idiopathic arthritis. Oligoarthritis means affection of 4 or less joints. Usually it affects large and weight-bearing joints, usually asymmetrical arthritis. Children appear to be well despite of limping. In cases of asymmetrical arthritis, chronic inflammation leads to overgrowth of that limb as shown in this figure with subsequent leg length discrepancy. Chronic anterior uveitis is common with oligoarticular juvenile idiopathic arthritis, especially those with ANA positive. So, children who were 6 years of age or younger at the onset of oligoarthritis and have positive ANA should be screened by slit lamp regularly. Polyarticular JIA means affection of 5 or more joints. In cases of polyarticular JIA with rheumatoid factor positive, the typical presentation is symmetrical involvement of small joints of the hands, especially metacarpopharyngeal joint, first interpharyngeal joint. Also rest usually affected. Rheumatoid nodules may develop, indicating a severe disease. Systemic features such as low-grade fever, fatigue, loss of weight, and appetite can be seen. Systemic juvenile idiopathic arthritis is a type of childhood arthritis with many extra-articular features. The physical examination shows the child appears systemically ill. There is also arthralgia. The child may have generalized myalgia. Characteristic evanescent salmon pink malar rash. This rash is usually associated with fever spikes. There is also hepatosplenomegaly, lymphadenopathy sometimes present. There is also serositis, including pleural, peritoneal, or pericardial effusion. These figures show the evanescent salmon pink rash on the chest and arm. As regards psoriatic arthritis, it is characterized by the following: monoarthritis, dactylitis, involvement of distal interphalangeal joint, tenosynovitis, and nail involvement as nail pitting. In enthesitis-related arthritis, the enthesitis is commonly seen as a calcaneal insertion of the Achilles tendon, plantar fascia, and the tarsal area. The arthritis is typically asymmetrical, commonly affect joints of the lower extremities. Also, involvement of the hip joint is characteristic clinical finding. As any sheet, the rheumatological sheet should fulfill the following items: the personal history, including name, age, sex of the patient, usually taken from the parents of the child. Complaint: usually the child of juvenile idiopathic arthritis complain of joint pain or morning limp or gelling phenomena that improve with time, or history of school absence or limited ability to participate in physical education classes. After taking the personal history and the complaint of the patient, we will go to the present history, in which we do analysis of the complaint, including the onset course and the duration of the complaint. In cases of children with JIA, the onset usually insidious onset with progressive course and the duration of the disease more than 6 weeks. As regards analysis of pain complaint, we should fulfill the following items: site, radiation and character of pain, diurnal variation, wrist pain or usage pain, what increase and what decrease this pain, associated symptoms such as stiffness, redness, or swelling, associated extra-articular symptoms. As regards analysis of the swelling, we should differentiate whether is it bony or hard swelling, firm swelling as in cases of synovial thickening, or fluid swelling with positive fluctuation. And we should pay attention to the signs of inflammation such as pain, hotness, redness, and limitation of movement. Also, in the present history, we can ask leading questions for the patient, such as asking about the movement, whether it's limited or not, the deformity, whether it's fixed or correctable. We can also ask about the muscle weakness, especially in the extensors in cases of oligoarticular JIA. We should also ask about systemic features such as fever, fatigue, or malaise. We should ask about extra-articular manifestation which can help us in the diagnosis, such as skin manifestations such as rash or salmon pink rash in cases of systemic JIA, nail changes such as pitting in cases of psoriatic subtype, if there is any cardiopulmonary manifestation such as dyspnea, chest pain, or cough, also in systemic JIA. We should also ask about eye manifestations such as redness of the eye, which may indicate conjunctivitis, episcleritis, or scleritis, or iridocyclitis, especially in cases of oligoarticular subtype. We should also ask about any gastrointestinal manifestation such as hepatosplenomegaly in cases of systemic JIA. After taking the personal history, the complaint, and the present history from the patient, we should take the past history and family history. In past history, we ask about similar attacks, infection, any autoimmune disease, or any relevant past medical condition or surgical condition or hospitalization. In family history, we ask about similar condition in the family, if there is consanguinity, if there is musculoskeletal diseases running in the family, such as rheumatoid arthritis, gout, or osteoarthritis. Examination of the rheumatological case include general examination and locomotor examination. In general examination, we should pay attention for the vital signs. We should examine the patient for the presence of pallor or cyanosis or jaundice. Also, we should examine the face and scalp of the patient, especially in cases taking steroid for a long time. We should also examine the eye, especially in cases taking steroid or chloroquine therapy. The general examination should also include examination of mouth for ulcers, neck for lymphadenopathy, muscles for wasting, skin for rash or nodules, heart for murmurs, chest for pleurisy or pleural effusion, abdomen for splenomegaly. The locomotor system examination includes inspection, palpation, and movement. As regard inspection, we should carefully examine the patient for any skin changes, swelling, deformity, muscle wasting, and attitude or the position of the affected area at rest is very important. By palpation, we can notice the warmth or tenderness or swelling of the affected joint, the deformity, whether it's correctable or not, and the muscle state, whether normal or atrophied, and the muscle power. From the most important items in palpation is the examination of the knee for effusion. We can find fullness of the parapatellar fossa and bulge sign in cases of smaller effusion, while patellar tap test and ballottement test are useful in cases of moderate and large effusion as seen in the figures. After inspection and palpation, we go to movement. Types of movement: active movement by the patient himself, passive movement by the examiner, or range of motion. In cases of limited motion, we should compare between active movement and passive movement. For examination of the upper limb and lower limb joints, please carefully see the video in the following link. Spine examination is very important item in rheumatological sheet. We should inspect the spine to show the normal cervical and lumbar lordosis and thoracic kyphosis and detect any abnormalities. For example, scoliosis, lordosis. Also, movement of cervical spine is very important. For example, there will be decreased cervical spine extension in cases of cervical spondylosis. This figure shows clinical examination for scoliosis, while the patient bent forward and the examiner side horizontally down the entire spine from the behind. The patient leg must be fully extended at the knee. Sacroiliac joint examination is important part in rheumatological sheet. The following tests are used to detect any sacroiliac joint dysfunction, such as distraction, thigh thrust, Faber test, compression test, and Jensling test. You can use these links to show the detailed musculoskeletal system examination. Thank you. You can use these links to show the detailed musculoskeletal system examination.